Well, let's move into talking about side effects. And you all have already alluded to the importance of dose modification with regard to side effects and minimizing toxicity. So I'm going to go to you, Dr. Ermann. What techniques do you use in your practice for optimizing treatment efficacy while minimizing toxicity? And feel free if you'd like to share a specific example.
Yeah, great question. So in CLL, there's a lot of unique toxicities with our CLL-directed therapies. I'll take, for example, BTK inhibitors. So BTK inhibitors have certain off-target effects. Uh, the way these medications work is they turn off BTK, and that's like flipping a switch that decreases the growth of the CLL cells and eventually causes them to die. However, some of the unique toxicities we see are things like atrial fibrillation, bleeding, bruising, infections, to name a few. So, for example, you would like to start a patient optimally on the maximum dose, which is the kind of recommended starting dose. However, let's say a patient gets a side effect such as bleeding or atrial fibrillation. I usually will follow the package insert pretty closely. In most cases, the recommended management is to hold the drug till a side effect resolves and then resume at the same dose. In my practice, I found that with many of our novel therapies, there are some cases where you can continue the same dose, but oftentimes you'll need to dose reduce. And I will say from my personal experience, I think dose reduction can make a big difference in the side effect profiles of these medications. I've seen reduced bleeding, for example, reduced rates of atrial fibrillation. With BCL2 inhibitors, I've seen reduced rates of neutropenia, for example. And I'll just say from my experience, I haven't seen too much compromise in efficacy. So I think I would recommend for providers when you're thinking about dose reduction, it's really a balance of toxicity and efficacy. And I think with just how good our treatments are for CLL these days, I try to reduce toxicity. And I think in that way, it does maximize their efficacy.
Thank you, Dr. Ermann. What about you, Dr. Chang? How do you approach dose adjustments for CLL patients, particularly those who may be experiencing severe side effects? And what factors influence your decision-making process?
Yeah, so first of all, I agree with Dr. Erman that I think trying to mitigate side effects and oftentimes following the package insert is really helpful. One of the things that I want to add though is I do spend quite a bit of time before starting any medication educating patients and trying to teach them about what potential side effects, what to look for, and importantly, if there are mechanisms to mitigate or prevent those side effects, I would spend quite a bit of time talking about that. And these can be things such as taking caffeine to prevent acalabrutinib induced headaches, for example, maintaining adequate fluid intake and hydration to minimize the risk of tumor lysis, and so forth. I find that by spending that time with patients ahead of starting therapy, that oftentimes it allows patients to identify the side effect and also start addressing it even before needing to come back to the clinic. My team, in addition to myself, also spends quite a bit of time, and we perform phone calls, follow-up phone calls, and things like that that are conducted by my pharmacist or by my nurse. And together, I find that oftentimes just by talking through these potential issues, patients will feel a lot better. Now, depending on how severe an adverse event is or a side effect is, I tend to potentially dose reduce somewhat quicker, or if there's an alternative, like in the case of BTK inhibitors, I will be a little bit more prone to switching from one BTK inhibitor to another, because there is data suggesting that if you don't tolerate one BTK inhibitor, you can tolerate a second one. And that's particularly true if we are seeing some of these side effects that arise in the long term, particularly with ibrutinib, and switching them to acalabrutinib or zanubrutinib, oftentimes resolve those kinds of side effects. And I've seen that particularly true in cases where I see hypertension induced by ibrutinib. I have a couple of patients where they are 4 or 5 years into ibrutinib therapy, came in with uncontrolled hypertension. I switched them to another BTK inhibitor, and the hypertension gets better control.